All right, so let's jump back to VAERS. So VAERS is that national tracking system we've had for all vaccines for decades. So clinicians, if they see something that they think might be related to a vaccine event, they will report that into the system, and CDC is required to investigate every single one of those cases. So they've investigated those cases. That helps us inform what things clinicians need to look for after they administer the vaccine. It also can raise a red flag if something happens that shouldn't be happening. So, the things that we've seen so far in the vaccine, we'll talk about each one separately. So, myocarditis is basically inflammation of the heart. And we've seen that in the medical community at a rate of less than one case per million doses, and primarily in males under the age of 30, typically who have certain medical conditions. Most of these cases are super mild. They're not even detected until you look for them. But that is something that is on the radar of ACIP. That is something that can happen with administration of the vaccine in people under 30. So that one has pretty much just been isolated to Pfizer. I haven't seen any reports really of that happening with Moderna. As far as which vaccine is better than the other, I really don't personally have a preference. As far as long-term immunity, Pfizer and Moderna are very, very similar. Johnson and Johnson is a little bit shorter, but it's really a good vaccine, I think, for younger people, 20 to 30, if they only want to get one shot. Now, the one risk though with Johnson and Johnson is the potential for blood clots, which is something that we now observe for and clinicians know how to treat for after the administration of Johnson and Johnson. Now, that's more of a risk with women. Another side note on that is birth control can also cause blood clots at a higher rate than this vaccine does, but still a risk of three cases per million doses. So that's one that's been documented. Anaphylaxis, this can really happen with any vaccine, mainly because, when you do these clinical trials, even if you have tens of thousands of people in those clinical trials, you can't identify every permutation of human um, genetics to find the people who might be allergic to it. So, all vaccine administration sites are required to have medications that can immediately treat anaphylaxis. And most of those reactions are things that happen within the first 15 to 30 minutes. So, when you're screened for the vaccine, you should be asked if you have a history of blood clots, if you have a history of any heart conditions or issues, if you have issues taking vaccines or like a bee allergy, bee sting allergy, or other allergy. And if you do, you might just have to sit and be observed a little bit longer after the vaccine than other folks. This last one, Guillain-Barré syndrome, is typically a temporary neurologic issue. This happens also with other therapeutics, with other vaccines. It's a rate of 13 cases per million doses. Almost all cases fully recover. It can be a little bit scary, if you have that type of reaction. But again, that's one where clinicians should be able to recognize it quickly and act upon it. Okay, on to some other myths and challenge. Children are only now being tested. No, kids were tested before too. That really test availability doesn't have to do with age. It has to do more of where is the actual availability. So, like I know in my state, we really have run into a lot of testing issues because we had such a big surge of people. So it's been difficult to get tested. My son was tested a couple weeks ago and he was sick. It took 8 days to get his results. It takes about 3 days to get results at the state lab. So every place is a little bit different, but kids should be able to access testing as much as adults. There are no long-term studies of vaccine safety and efficacy. There are, and they are still going. So these studies will go for a minimum of 2 years total, and they'll look at people for a very long period of time. But I think it's important to note that, when you think about how a vaccine works in a body, most of the things that you'll see that are related to the vaccine will happen within the first 3 weeks after you get the vaccine, and even sooner than that. So if you have something like myocarditis or blood clot or an allergic reaction, those happen typically pretty quickly. Guillain-Barré can be a little bit later, but all people who were part of clinical trials are still being monitored. And mainly they're being not monitored now, yes, for long-term effects, but also to see how long those antibodies protect. And that's part of what's helped inform the booster dose recommendation. The government is using the vaccine to track you. I think this one's a little funny just because I don't think our government is that clever or able to do this. I work with CDC on a regular basis, and they're the smartest people in the world, but they have 700 data systems. They can't even coordinate those. So to think about the government being able to put nanoparticles in the vaccine and track you is really, I think, a stretch of their ability. But if you think about just the practicality of that, the vaccine comes in multi-use vials. So every person who administers a vaccine has to draw up a dose. If there really were nanoparticles in there, they'd have to get that nanoparticle in each single dose, get it injected into you, and then the government would have to figure out which nanoparticle you have. It's just not a thing. So I wouldn't worry about that one. And side note, the kids vaccine 5 to 11 Pfizer is different than the adult version. It's a third of the dose. It's got a different label. It's got a different injection quantity. So it's pretty much totally different vaccine, except for the composition is the same. It's just a smaller dose. The vaccine was made from aborted fetal tissue. This is an interesting one and has come up with other therapeutics over time. So what I'll say about this one is, okay, so in 1960, 1970, there were two cell lines, from what I understand, that were obtained through either spontaneous or intentional abortions. Those cell lines have been used in research for decades. And really, honestly, anytime you have a human therapeutic, you need to see how it reacts in human cells. And so those cell lines are not from like recent abortions or continuous abortions, they're perpetuated. So you start with those fetal cells, and you start with those cells because they can replicate really, really well. And those cells don't turn into, a certain tissue or certain function. They're not determined. So by using those in research, you can see exactly how they affect the progression in the human body without it actually being in the human body. So no, we're not using aborted babies in research. It's not really an issue with Pfizer or Moderna anyway. How is the presentation frozen again, Brittany?
Yes, I think it is. We're still on the myths and challenges.
Yeah, I'm still on myths and challenges, but you're not seeing any graphics?
No. We're on slide 15 is what we're seeing.
Okay. Slide 15. I don't understand what the lag is, darn it. Let me, gosh, I don't know if taking off my headset would help. I'm going to stop share again for a minute and reshare and see.
Yeah, we're seeing 16, not 15.
Oh, good. Okay, that's what I'm on.
Oh, so maybe the internet on my side is slow. It very well could be, but
okay.
I'm on a little Wi-Fi, so.
Okay, so consensus, we're all on slide 16.
Now all I see is your.
It used to be, but it's gone now. But you were on 16.
Okay, so then, so if you share it again, because.
Okay.
Internet issues, technology.
I know. This ruins the rhythm. Okay. I'm
well, you're doing great.
Sharing.
So.
Oh, thanks. I'm taking my time today. I hope that's okay. So we're just trying to cover all the bases.
Yeah.
Okay.
Well, I sent you a lot of questions.
That's fine. You should see myths and challenges and 3 graphics.
Is everybody's
No, not seeing anything yet.
Nope. All I see is your initials.
I see sheet 16.
Okay, so some people are seeing page 16.
If I advance to women and COVID, fertility and pregnancy, can you see that?
I see 17, yes.
Okay.
I see 17 as well.
Okay, so a lot of people are seeing 17 then.
Okay. Okay, well, I'll wrap up myths and challenges and we'll keep going slowly and hopefully the internet will keep up. I'm so
Yeah.
sorry, you guys. Like there's literally nothing else on in my house, so I'm not sure what's going on. All right, so last note about fetal tissue. It's not really an issue for Pfizer or Moderna, so not really used in the development of those, but just know that, I mean, this was decades and decades and decades ago. There are many different human fetal cell lines that are used in research that were obtained from those two original sources, and honestly, some that were used from cancer patients too. So it's not that we're continuously retrieving those. Those are just used in research, and they're from way, 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 way long ago. So, and even the Pope says it's okay to get vaccinated. So I just throw that one in there too. So, not that the Pope is a scientist, but that means a lot to some people. Okay, women and COVID. I'm not going to spend a whole lot of time on this because this is a lengthy issue, but I want to at least give you all the information in the slides. And you can come back to this if you're somebody who's concerned about this, or if you have a partner, a wife, girlfriend, even daughter that you're worried about with fertility. This one, with all the recent information we have, has pretty much been put to bed, and we feel really good about this. And actually, what the challenge is now is that only 30% of pregnant women are vaccinated. And there is a significant portion of pregnant women who are going into labor early because of COVID, are sick with COVID at delivery, and their babies end up in the NICU. So there are a lot of adverse outcomes that are happening because pregnant women are very susceptible to COVID. We see the same thing with flu. We saw the same thing with pandemic flu. The pregnant body is already reduced in its ability to fight infection because you're supporting another life, but you're also physiologically challenged in trying to get rid of a virus. So pregnant women it's super, super important to get vaccinated. But let's talk quickly about fertility. So I've heard about impacts on periods. Yes, anytime you have any type of vaccine or medication, it can interfere with your hormone cycle, though not like permanently affecting your cycle. It's just the systems in your body are related to each other. So you stress one, you're going to stress another. You stress your immune system, you're going to stress your reproductive system. Um, and sometimes that happens with people, you might miss a period or have a delayed period after the vaccine. According to the studies I've seen, it maybe happens 15 to 20% of the time, but your periods come right back. It's not an issue. No impact on fertility. So there's no long-term effects. There really isn't a biologic mechanism for that to happen. Because like we talked about before, vaccines really work the first 2 to 3 weeks after injection, and then they're expelled from your body. Your body takes care of them. So they don't hang around forever like the chickenpox virus. It just comes and goes. Your body deals with it. There's not an overlap of the spike protein or the S protein and a placental marker. So now we have a couple of really big studies. This one that I have cited below here looked at, I believe, 2,500 pregnant women. And now we have a study, I think this next one, that looked at over 5,000 women. And then there was another study with 155,000 women. All of those women were examined for, okay, how many had spontaneous abortion or stillbirth, preterm birth, small babies, genital anomalies, or a baby die, and then how did that rate compare to what we see in society as a whole? And the rates were no different. And actually, in fact, some people who are pregnant had better outcomes than people who were in the general population part of the study. And there's multiple studies on this now in multiple countries. So because of that, the American College of Obstetricians, Reproductive Medicine, and even this statement is from February. We have many subsequent statements since then that basically say we've got a lot of data now. We understand it's safe. We know it's safe, it's effective, and now we've really got to protect those pregnant women and those babies. So pros of vaccination, we have 42 studies, over 5,000 pregnant women examined, 155,000 pregnant women in our registries for which we have clinical data that show that it's safe and effective compared to people in general population. Some benefits of vaccination are that if you're a mama and you are going to have your baby soon, the antibodies you develop from vaccination go to your baby, and your baby's born with those antibodies. And then if you breastfeed after birth, that reinforces those antibodies even more through breastfeeding, which is awesome. Vaccines only have a short-term effect of the body, so that's why you don't need to worry about fertility, or if you have a teenage daughter who wants to have babies later, not an issue. Cons of not getting vaccinated. We're seeing more women, pregnant women, have to go to the ICU, need ventilation, go into labor early, have a spontaneous abortion, have preterm babies. They're more likely to have preeclampsia, massive complication, more likely to die from COVID. And then all of the other really, really unfortunate things that can happen if you have COVID and you're a pregnant woman. And this is irrespective of age and comorbidities. Okay, I know we're going on and on here, and I'll try to pick it up a bit. Let's talk booster shots. So why the heck do we need booster shots? And why was there so much confusion around this? Honestly, and I try to be apolitical in these conversations, but I think our administration kind of jumped the gun in saying everybody needs a booster 2 months ago. We didn't have all the science in yet. So what do we know as far as the science goes? We know that people over 65 are not holding on to their immunity quite as well as we'd hoped. So we have those studies in multiple countries. That happens, honestly, though, in people who are 65 and older anyway. They don't hold on to immunity very long. So if you're 65 and older, for example, your flu shot is like a super flu shot because your body just doesn't work as well as it did 20, 30 years ago. So that's been one of the target groups. But we also know that boosting in other populations does help even further reduce anybody getting breakthrough disease or getting serious illness or death. So that's why there's these additional groups of people. The one thing we don't know in the science yet, but I think we will soon, is if you give a booster dose, does it reduce the ability to spread disease from person to person? We don't really know that for certain yet. So that, I think, is the hesitation that you might have seen in, oh, everybody needs booster doses, and then kind of tempering that back to, okay, maybe not everybody needs booster doses yet. So if you were vaccinated more than 6 months ago and you are in one of these groups, 65 and older, you live in a long-term care facility, you have underlying health conditions that we covered earlier, if you work in a high-risk setting, or if you live with people who do, it's time to consider that. And you had Pfizer. So we only have booster for Pfizer right now. But when Moderna comes out and their booster dose is going to be a half dose of what their original dose was, then it would be time to consider that too. I don't know if we will open up booster doses for all people until we have that question about transmission answered. So we need more science to make a better decision for the general population. Okay, where do I go for good information? Man, this one is really hard. It's really hard. And I cannot imagine, if I were not an epidemiologist, how hard it would be to navigate this situation and for this long. It's definitely tough. So the places that I usually send people are, first of all, don't look at this stuff every day. It's exhausting. The bad sources of information, and I say bad, just because, again, this is tough stuff to digest. Any news organization that's a generalized source, your CNNs, Fox News, even Washington Post, not really amazing because they don't always have science writers. They don't always have the clinicians that have the right background to adequately interpret the science. So I stay away from getting medical advice from those sources. Personally, I look to CDC first, and I just look at the CDC data tracker. And the data tracker is very straightforward. It's updated every single day, and it gives you a color-coded interpretation of what's happening where you live right now. I love it. It's great. It's easy. So I go to the data tracker. I can put in my state and my county. I can look at the transmission level. I can see how many people are vaccinated, what the cases are doing. I can look at that curve and make an informed decision about what I need to do to protect me and my family. Great source of information, and it comes from the states themselves. So good source. Your state health websites, public health agencies, all of those are good sources of information. Clinical sources, sometimes good, sometimes not. It just kind of depends. Like if you're Mayo Clinic, you're going to have good information. If you're a rural hospital, you might not have all the complete information that you might need to make a decision. I know it might seem a little bit biased, but the New York Times actually has pretty exceptional data. They have some articles, sometimes there's bias in those articles, yes. But they do have good scientific authors. And what I appreciate about the information they have is that if you want to just look at the data, you can just look at the data. You don't have to read anything that they write. You can just look at the data. Most of that's public access. So they do what CDC does too, only you can see the global perspective. You can also see a county level distribution. Their graphics are a little bit different than what you see on CDC site. So I love the New York Times site. And the other thing I love about CDC and the New York Times as a scientist are that I can go directly to their data and I can look at their data and make sure it's right. And that gives me a high level of assurance. Because if you have a site that's just posting stuff and they're not telling you where they got the information from, that's suspect. So those are the two gold star sources of information that I use regularly. Johns Hopkins has a nice fancy dashboard. I think it's honestly a little hard to navigate, but some people really like that source, and it does give you state and county perspectives. Words of caution. Avoid listening to people who are not folks who have a strong background, especially if you sense that there's bias in their position, whether it be political or personal. If they're not sticking to the science and really speaking about, well, I've read, and I can tell you, I read at least 20 articles a week on COVID. As exhausting and redundant as that is, the science is always changing. And so, as science questions itself, I need to be questioning science too and finding good information. So, infectious disease people who understand how viruses infect people and affect people is important. People who are pharmacists, have degrees in pharmacology, epidemiology, they have all received special training. Not all clinicians have. I think a lot of clinicians are well educated, but not all clinicians know how to read scientific literature. So sometimes there's some gaps in knowledge there. I would not get COVID advice from, say, a spine doctor or a chiropractor, even though I have a chiropractor and he's fabulous. He is my back doctor. He is not my immunologist. So just be wary of those types of things. But at the end of the day, you got to go to the people that you're comfortable with. So your personal care doctor, your public health agency, if those are the people you trust for information, those are the people you should go to. And those are the people who should be striving to get the best information for you. Remember that the FDA, yes, it is an organization that has humans in it, but they are not financially or otherwise motivated to keep therapeutics from people. Quite the opposite, it's their job to get the right therapeutics out that are proven, that work, and that don't cause more harm than good. Other points to consider, there's always lags in reporting. So when you might see a surge in the data, you see your cases are going up, that surge probably happened a couple days ago or is happening a little bit less than real time because it takes time to get people tested. You're always going to see hospitalizations rise, and you're probably going to see a lot of media about how many deaths are occurring now because we're coming out of a surge, and deaths always take a while to hit the media and to hit the data after hospitalizations. And I hate saying this as an epidemiologist because I do forecasting, but a lot of forecasts, especially long-term ones, are not super valuable right now because the virus changes so much. So if somebody tells you that we're going to have a COVID surge December 15th of 2021, in 2 months, I would not believe them because nobody really knows. So what we do know, the next 2 to 4 weeks, we have good sense of what's going to happen there. And we can also look at what happens in other parts of the world and other parts of the country to anticipate what will happen in the near time for us. Here's that mask graphic I mentioned. So if you want to know more about masks, what's good, what isn't, some mask is better than no mask, but man, there's a lot of variance. So feel free to steal this. This is, I think, a combination of EPA, maybe NIOSH, NIH, CDC. They've aggregated hundreds of studies modeling real life to put this information together. And then this one I wanted to mention too. So I talked about how, last year we didn't get exposure to a lot of viruses. This year we're getting exposure to viruses. And so what we're seeing is a big increase in RSV, parainfluenza, regular human coronaviruses that are non-COVID, and some other pathogens. So we know the viruses are getting a hold of people and therefore get your flu shot. This is a big deal this year. Here's a graphic I also mentioned. This is one of my favorite of all time. My husband makes fun of me because I made this like 10 years ago and it's still my favorite graphic. This is just a really straightforward illustration of how temperature, this is the background here, affects flu. So we have a lot of viruses that are temperature dependent, but you'll know when your temperature drops, that's when flu will surge. And as you can see from the different colors, your risk of getting multiple flus each year is very real. We usually have at least one dominant A strain and one dominant B strain.
Hey Meg,
Yeah.
at the end of this at the end of the meeting, can you send me like the graphic of the presentations? Because like there's a bunch of us
Oh.
that still can't see the
Oh,
graphic.
shoot. Okay.
So
Yes,
if
I'm
you
so
could,
sorry. Okay.
that's okay. So, but we can, if you could send me like the
Yes.
handouts, so that way when I
Yes.
send it out, the recording, then everybody can kind of keep up, I guess.
Yep. I sure will.
Cool.
And actually, as soon as we get to the question part, I'll try to flip this out too, and you can distribute it in
Okay.
case anybody wants to flip back through and ask questions.
Okay, cool.
Okay, just a side note here about future stuff. So, American Rescue Plan, the second part, the CARES Act was the first iteration of this, is going to do a lot for our public health workforce, and it's very, very much needed. So, post 9/11, public health got a ton of money. We built all these plans, and then through multiple different administrations, reduction in funding. And so when the pandemic hit, public health was really in its worst state that it's been, and I can't even remember. So a lot of funding being put into those organizations, better surveillance, better predictive analytics, more modernized data, better case surveillance, and so all of that should be improved. So I'm going to escape out of here. I'm going to send this to you quickly and stop sharing. And then I think we'll start going through some of these questions too. So let me save that quickly. And you should not be able to see my screen now.
Okay.
Okay. Just get this saved here. Okay, and then I'll get this sent over. Okay, one of the first questions I see here is the vaccine effective against variants? Yes, it is effective against Delta. So we talked a little bit about how you can still get infected, but not necessarily have disease. And that's true of this too. And sorry, Brittany, I'm going to send this over to you now.
So I think when you guys, when you're kind of done with the ones that we already got, we'll just have people raise their hand and they can ask the question and I'll just call on them.
Okay. Okay, sorry, I'm getting this over to you now. Okay, yes, and feel free to send that out. Okay. And I'll go ahead and just share this screen too. And one other side note I'll say is that if you personally have a question and you're not comfortable asking it on this session, I put my email in here. You are welcome to contact me with that question. I'm happy to take that. That's no problem at all. Okay, another question. Are other countries advocating one shot over two shots? No. But what was confusing about what the UK did is they earlier in the year had a different approach or different strategy in the United States. So their goal was to get as many people vaccinated with one dose as possible. So that's one thing they did that we didn't do. So they spaced their doses more. They said, everybody get your first shot. And then they allowed people to get their second shot up to 12 weeks after. They also allowed people to mix vaccines, and they also had different vaccines available than we did. So different approach, but by and large, that recommendation of dosing should be the same for each individual vaccine, regardless of where it's administered. Okay, so I think we talked about social media and the information about side effects, all of that is readily available. Yes, read about that. Ask your clinician about it if you have questions or concerns. That is totally warranted, and I definitely get that. I have done the research myself. Trusted sources. So the trusted sources most clinicians I think use are their professional organizations. So they might go to the American Academy of Pediatrics, the medical societies, American Medical Association. Obstetrics gynecologists have two organizations they go to, get a lot of info through those. A lot of them look at research articles too. And a lot of them go to places like New England Journal of Medicine. So if you want to geek out on COVID research, New England Journal of Medicine publishes all the vaccine data, and they do a really good job of allowing research and scientific dialogue on their site. So you can see where scientists question each other. And so that gives me some assurance that, okay, smart people are questioning smart people. Let's see how this plays out. Let's make sure the science is good. lots of Oregon government commercials talking about how the vaccine stops the vaccinated from spreading COVID. It reduces the amount of time that someone, if vaccinated and infected, can spread COVID. That's true. But it doesn't prevent infection altogether all the time. And that's mainly because this virus spreads so quickly and it replicates in your nose before your body can fight it. So that's kind of a so-so answer there, but it's not super straightforward. Why do we need a vaccine when COVID has a high survival rate? It's a great question. Multitude of reasons, and I hope we've covered all of them today. So it's about individual risk, yes. Most of the people in our population have one risk or another. They might have multiple risks, especially, like I said, if you're over 40, but even younger people are at risk, and you never know who that's going to be. What we also know about this virus that to me is very scary is it causes a massive amount of inflammation in your body. So it comes into your body, causes a scourge of infection, and then your body's response to it releases a massive amount of inflammatory um, stuff in your body. And that inflammation has caused long-term COVID in a huge proportion of people who have had serious COVID. So everything from depression to brain fog to long-term anxiety, the inability to taste or smell for months on end, trouble with sleeplessness, with focus. These are cognitive issues, and you don't see that happen with other viruses. That is unusual. So to get vaccinated and know that if you are vaccinated, and even if you do happen to get Delta, your risk of having that long COVID or severe infection is negligible. So that's a good thing. The other part of that is more altruistic. You're not spreading the virus. You stop it from continuing to spread by and large if you're vaccinated. The more people we do that, the more we squash this, the less it can mutate. Those are all really positive things. And we've been through this kind of a cycle every time we've gotten a vaccine. Every new vaccine, sometimes it takes a couple of years to get people on board to really understand the science and the reason for it. So that's not necessarily unusual. It's just we're on a tighter timeline now because we're in a pandemic. We talked about contents, no heavy metals in the vaccine. You can read the ingredients on CDC and or the manufacturer's sites. That's pretty easy information to find. But there's no metals, no carcinogens, no neurotoxins that are in that. And honestly, if you think about household products, I think 1 out of every 100 is tested for human harmful effects. So if we were going to start to talk toxicology, we should probably talk about the chemicals we use to clean before we talk about what we're putting in our body. So, but I definitely understand the concern there. A question about hair loss, and so strange, but I heard this one earlier today too. There really no scientific reports or research of the effects of hair loss from the vaccine. So I haven't seen it. Does it mean it's not a thing? It's not likely or probable, and I can't think of a biologic mechanism for that. So it shouldn't exacerbate a problem. I mean, like I said, though, when you are immunized or when you're sick or when you have something that happens to your body, those systems are all connected. So sometimes you can have other effects from being sick or being vaccinated, but I wouldn't be worried about hair loss in particular. I had a couple questions about vaccine preference. I think we talked about that. I don't really have a preference. Pfizer and Moderna, they're both good. They're both very, very, very similar. Johnson & Johnson's fine too. Single shot, but we definitely have more data and research on the Johnson & Johnson and Pfizer in particular. And safety-wise, there are the risk factors that we walked through. I think Moderna, if that's really something that you're concerned about, not really the issue with potential myocarditis with Moderna, even though that's less than 1 case per million. I got Moderna, my kids got Pfizer, and so those experiences were all fine. But you should be aware if you haven't been vaccinated that you probably will feel it. So if you're a little bit older and maybe you've had your shingles vaccine or first time you got your flu shot, your arm might be sore. 12 hours later, up to 24 hours later, you might have a fever. You might feel yucky. You have to remember this is a pathogen your body has never seen before. So it's going to react to that vaccine just because it's new. But that also means that your body is seeing it and your body is saying, hey, I need to remember how to fight this. I'm fighting it. And then your body's going to remember how to fight it. So, great questions. We talked about booster shots. Flu shot, you can get your flu shot with your COVID shot. You can also get your flu shot with your booster shot. So you can get those at the same time if you want to, or you can space them if you want to. It's really up to you. But right now is a great time to get the flu shot. And then I had a question about if you've gotten vaccinated, testing positive for COVID. So the PCR test that is typically used, and even rapid tests, the vaccine shouldn't make those tests turn positive. Is it possible to get COVID illness right after vaccination? It is, because you don't develop full immunity from the vaccine until 2 weeks after your second dose. So you can still get COVID until you reach full immunity. After that, you should be very well protected. But you even get protected from one dose too. I think we talked about the effectiveness and even from a statistical perspective. I'm just looking through the other questions. And then there was a question too about, oh, Brittany, did you want to say something?
I had somebody ask a question. So if
Yeah.
they've had COVID, how
Mhm.
long should they wait until they get vaccinated? Because we've heard different things.
I
Like
believe
doing
it's
90 days.
90 days. I believe it's 90 days. I would ask, call a pharmacy or call your doctor's office ahead of time or wherever you plan to get the vaccine and just see what they say and confirm that because they should know. But I think 90 days is probably sufficient because
Okay.
you don't have to quarantine again if you had COVID for 90 days and you think you have it again. So that's kind of a nice thing. But yeah, I think that's how long you should wait.
Okay.
I did have one other thing about Singapore outbreak. They have 83% vaccination. And okay, so what has happened in some of these other countries? Singapore, Israel, a couple of other countries have really high vaccination rates. Part of what they're finding are just positive people who don't know they're sick or who don't know they're infected. So they have a huge testing program. So they're testing in schools, they test when you get to the airport, they test in the public. Like testing is pervasive. And the same thing in Europe, they're testing everywhere. So, what happens when you test a bunch of people is you're going to find some positives in there that are asymptomatic, or they're just infected, don't know it, or they're mildly and infected and mildly ill. And we know that vaccinated people can potentially contract COVID, this Delta variant being very exceptional. And one example I'll give you, even the United States, and how we found that Delta was so transmissible is we knew it was going to be in the United States after a 4th of July parade that happened outdoors in Massachusetts. And it resulted in several hundred cases, but I think 80% of those cases were not symptomatic, and most people were vaccinated. They were just positive, so it was spreading, but nobody was becoming sick, and they weren't spreading it for very long. So, still a good amount of protection. Yes, Delta is special, but that's part of why you see what looks like a surge in other countries is they're actively seeking the virus and trying to find out who's positive. So I hope that explains that. What other questions have come in, Brittany?
So if anybody has any other questions, you're more than welcome to either raise your hand and ask yourself, or you can type me a note. Oh, let's see. Okay, it looks like Derek has a question for you.
All right.
Go ahead, Derek.
Let's see. So for VAERS, I'm curious as to for reporting, how long is it that they kind of watch over people for the sake of reporting? Is it the 2 weeks? Is it 2 days? Is it I don't know how long it goes.
Indefinitely, honestly. So for VAERS in particular, that registries for all vaccines, and at any point in time, if a clinician feels that there could be a connection to the vaccine and an adverse outcome, they can always report it. And it doesn't matter if it's 2 weeks, 4 weeks. Now, I will say there's a lot of garbage in VAERS, so there's a lot of reports that don't amount to anything. So that's difficult. Um, But yes, at any point in time, those flags can be raised and they all have to be investigated.
The amount of time it takes for reporting, like recording those for the hospital staff to do, I've heard it's kind of a lengthy procedure.
It can be, but that's why we have redundant systems. So that's why VSafe was put forward, and state health departments have to report these things too. So VSafe is looking at people reporting how they're feeling right after the vaccine, and they keep checking in with people. So even though it's self-reported, and there's some bias in that, if there are signals in those data that say to CDC and or FDA, hey, there's something that's happening that looks concerning. You know, like we have a disproportionate number of people who are developing fever or who say that they're sick for multiple days. If they start to see trends in those data that don't look like what they saw in the clinical trials, then they can pause administration of the vaccine. They can take a deeper dive in those data, and then they can look at the VAERS information in greater depth, because you do have to provide a lot of information with the VAERS report, but what's good about that is you get the clinical history and a lot of detailed medical information on those cases to really investigate them well.
With PCR testing,
Mhm.
do you know the details about, you know, the number of cycles that we do with it? Does it differ for the vaccinated and unvaccinated? Do they do multiple tests if it shows up positive or negative?
Mhm. Good question. So the PCR tests, I think there's over 200 of them now. There are quite a few. And the cycle times are determined in the CLIA laboratory approval process. So it just depends on the different primers and probes and polymerase, or the different components of the test that are used to do that detection. So early on, I know there was a lot of debate on, oh, we're running these cycle times that can amplify anything. At the end of the day, you either have virus in the sample or you don't. And if you have virus in the sample, you should be able to detect it with a good test. And a good test shouldn't require an inordinate amount of cycle time. So the tests that we have now are pretty well refined. So if it's a positive, it's probably a positive. Very rarely are those tests wrong. Where we run into some challenges is if there isn't a lot of virus in the sample. Either it can be unequivocal or undetermined, and then you would need to get tested again. With rapid tests, that happens more often, where the rapid tests are not as sensitive, so they don't always pick it up. So if you have a negative rapid test, it's more likely that you get a false negative than you would a false positive. So usually if the rapid test is positive, it's positive. PCR is positive, it's positive. If the PCR is unequivocal or indeterminate, then you probably need a second test to determine if you really have it or not. But you know, cycle times were a question maybe a year ago, but those tests are pretty solid now, and they've gone through a lot of evaluation, and they continue to be evaluated too. And actually with Delta, there's so much virus in those samples. I don't think the cytokines have necessarily changed, but I mean, you're going to have a ton in the specimen if you're positive.
I think that's a good case to go with, because obviously, you know, if it takes 2 cycles to get through, then, you know, it's the most obvious thing, and or you can tell that you clearly have it.
Yeah.
And, you know, if you're looking 100 cycles down, that's a lot of orders of magnitude. I know originally we were going around 40 cycles compared to other countries that were doing between 20 and 30.
Mm-hmm.
Do you know why that is, that we had such a higher, I guess, lower threshold?
Um, I know a couple of the specifics around it. One of the big problems that we had in the beginning is, so I talked about how trying to release the genome very early. It took us a while to get um, all of our supplies together at CDC, and they made a mistake. So their mistake was in the control samples that they put forth. And that doesn't necessarily have anything to do with the cycle times, but basically our tests took a little while to get to the point at which they needed to, whereas Germany had a test developed in 7 days after the genomic sequence was put together. So they had more time to refine their process. And the United States had a lot of variability, and all this. Every country has a different process for approving those laboratory tests. And not all the tests are used in all those countries. So the cycle time average that I saw was about 36. I used to run PCR tests. That seems pretty within the realm of reason. If it were 60, 70, I would be concerned. But Sorry, I'm getting some background noise now. But I think now we've settled into a good place where, you have a strong positive. Yes, you are still running cycle times above 30, but that isn't an unusual thing. So I hope that helps.
Thank you, Derek, for those questions. I think we'll, there's no other questions. We'll have Clint. Clint, you're up.
Thank you, Dr. Schaeffer, for your time today.
Yeah.
So on the CDC website, it states that there is 2 different Pfizer vaccines, one being the Comirnaty COVID-19 vaccine, mRNA.
Comirnaty. Yep.
Okay. And then the other one being the Pfizer BioNTech COVID-19 vaccine. Can you speak to that and what the differences are of those?
Oh, Comirnaty is just the commercial name for Pfizer. So
So
they made this exceptionally confusing by giving it a name a couple months ago, and that they'd never used that before. So that is the Pfizer vaccine.
So it's just the same vaccine.
Yes, it is.
Okay. Thank you.
Yeah. Yep. I could barely say that word. I don't know where they came up with the name.
Okay.
My husband was joking that they had one too many meetings on that name. And
Okay. Are there, does anybody else have any other questions for Dr. Schaeffer? While we got her on the line, and like she said earlier, if you don't feel comfortable saying it in this meeting, you can always send it to me, and I'll make sure she gets it. And at the end of this meeting, we'll send out basically a QR code with the recording, and then I'll get the slides from her as well, so that can help too. But now is your chance to ask her lots of questions.
yeah. Oh, sorry. One more side note. The Moderna vaccine is called Spikevax, which I think is also hilarious. So if you see that, it's not a new vaccine. It's just Moderna's name for it.
We have a quiet crowd today.
That's okay. Well, we spent a long time talking, so
We did.
yeah. Hopefully we hit on all the points. But yeah, like Brittany said, if you have questions, feel free to reach out to me. Totally fine with that. I do post periodic updates on my website. Yes, I use Facebook, even though I don't love to use Facebook because I think it's not always a great place to get information. But anytime you see an update from me in particular, and hopefully other EPIs and professionals, I reference everything that I put in there so you can look at the articles and look at the source yourself. And I think that's really important to do.
Okay, so if there's no other questions from anybody, I think we'll let Dr. Schaeffer go. And I really appreciate your time. I know there was a little technology issues today, but I really appreciate you taking the time out of your day and answering a bunch of questions. And that's all this is for, is just to get some more information, to get some of the white noise out. We get bombarded with stuff from Facebook and technology. And oh, Andy's got a question.
Yeah, go ahead.
Okay, so the question about Singapore, and I think it said they're 83% fully vaccinated, and they just recently had this spike. You were saying it was, because of testing and all that. So with them having such a high vaccination rate, how did they fare with this spike? I mean, was there a lot of hospitalizations? How did the people that were vaccinated do with the spike?
They're doing really well. And actually, if you look at some European countries that had the same thing, where they had a surge from Delta, they're looking for it. It's a more active surveillance approach, but their hospitalizations are pretty low. And that's good. But you can do that comparison in the United States. So if you look at the Northeast, where the vaccination rates are 70% or higher, depending on where you are, it's not universal, but their hospitalization rates never got out of control. But if you look at some of the southern states where the vaccination rates were around 50%, my state in Iowa, not being in the South, our hospitalizations surged. And now it's not necessarily a question of beds, it's people, it's healthcare workers, massive shortage, travel nurses that are charging a ton of money to work in those hospitals have really put a strain on the healthcare system. So the situation here is really different than other countries. But yes, Delta unfortunately took a hold on a lot of people in a way we didn't predict. Still, vaccines still protecting really well, but those countries like Singapore, being isolated, they can look for cases, whereas we're just still trying to find the ones that really are cases here. We haven't caught up to that yet. It takes a lot of work and a lot of proactive efforts to test.
I had a question come in. Andy, did that answer your question?
Yes, it did. Thank you.
Okay, I had a question come in and then we'll get to Derek. He has another question. If you can explain breakthrough infection and how often that occurs.
Yeah, so I think it's important to differentiate. I consider breakthrough disease when you actually get sick and you've been vaccinated. And so that there really isn't a number for how often that happens. It's more a matter of, if you have 100 people and 50 of them are vaccinated and 50 are not, the 50 who are not vaccinated are more likely to get sick and they're more likely to be hospitalized and die. So we know that's true. The 50 who were vaccinated, a significant proportion will probably get infected if they all have the same exposure, but maybe one will be hospitalized or get seriously ill, and probably nobody will die. And the majority of people who get infection will never have symptoms of disease. So it's totally different experience. It's just, like we've talked about, where the virus goes, it goes in a place in your body that it's hard for your body to see it. And there really is no way to tackle that unless we develop like an antiseptic nose spray or something that can attack those mucosal surfaces before the virus infects your body and causes disease. It's definitely not what epidemiologists wanted to see after we've been working through vaccination and talking through the concerns about that. It definitely helps. It makes a difference for sure, but nothing in this pandemic is 100%.
Okay, Derek, do you have another question?
I did, but I think I did now. It just she's actually. Can you provide me the source about the mass effectiveness? Is that in the presentation?
It's in the deck. Yep.
Yeah.
So that graphic, there's a whole section on slide 26 that has the references for masks.
Do you have another one for the difference between the rate of infection that a vaccinated and unvaccinated person spread?
Oh, I might have to add that in. And like I said, that's difficult because the problem is we don't know. Okay, we know of hospitalized people what percentage are vaccinated and which aren't. So about 90% of hospitalized people are not vaccinated, 90 to 95%. We don't really know in the community because we're not proactively testing people who aren't symptomatic. So we don't really know what proportion of vaccinated people have infection. It's just once they get sick, then we know, and it's a really small percentage. So unfortunately, there's not great data about that.
For the
At least
sake
not
of
in the US.
how much is spread, or how much an infection person, sorry, vaccinated person spread?
We know that their ability to spread is limited to maybe 2 days. It's a shorter duration, whereas if you're not vaccinated, you can spread up to 10 days. We know that for sure, but definitely if you have symptoms of disease. It can be less if you don't have symptoms of disease. So there's quite a range depending on vaccination, if you have symptoms, all of that.
Okay, so yep, that's it. Thanks.
Okay. Good questions.
Dr. Schaeffer, I know when I saw you speak before, you had mentioned the sample size of when they were doing the clinical trials and stuff. Did you touch on that? Did you touch on that in your presentation? I didn't remember. I remember being surprised that it was so large.
Yep. It was over 150,000 people worldwide in Pfizer, Moderna, and I mean, if you throw in the AstraZeneca and Johnson & Johnson vaccine, it's a huge amount of people. But just in the United States, Pfizer and Moderna, over 30,000 people had to be in those clinical trials. For kids, it's a smaller group.
And is that average or is that about normal for the sample size? Like if for normal vaccines?
It is, honestly, it's bigger than a lot of vaccines trials, but the way that those trials work is they might run like 3 at a time. And yes, Pfizer did that too. They had multiple centers in Moderna that were running that at the same time, but 30,000 is a lot of people. to include in that trial. And even still, like we talked about, you can't find everything, but that is a really substantial group, and those people will be followed for a minimum of 2 years.
Okay, and I just had another question come in. Let's see. Earlier in your presentation, you cited mutation prevention as a reason for getting vaccinated, but then later stated the vaccinated individuals could contract the Delta variant. Is there a reason to believe that mutations cannot or will not occur in vaccinated individuals who contract the Delta variant?
To a lesser extent. So to a lesser extent, because they're not causing systemic infection. So if you have a virus or multiple viruses that are infecting a vaccinated person, is a short period of time where that virus can replicate and do anything. But if you have an unvaccinated person, it can definitely infect them. It has a much greater chance of mutating or being infected with another strain, reassorting with that strain and resulting in something more severe. And I do think over time too, booster doses should help with transmission. We don't know that for sure yet. We're waiting, but the vaccine should also get better over time. And so it talked about hopefully they'll target parts of the virus that, regardless of the mutation, could prevent it. But we might also be in that perpetual state of catch up, like flu, where we have to change the vaccine every year. We don't know yet. Good question.
Okay. So does anybody else have any other questions for Dr. Schaeffer? It's all really good information. Okay. Going once, going twice. Okay. Well, with that, I think we'll end 10 minutes early. And again, thank you very much for everybody that attended. Hopefully it helped. And I'll be sending out basically a recording of this. And if you have any other questions, just shoot me a note and I will make sure that I get it to Dr. Schaeffer. So, all right. Thank you,
Sounds
everyone. Have a
good.
fantastic day. Thank you, Dr. Schaeffer, again.
You're welcome. Nice to meet all of you, and feel free to ask your questions.
All right. Sounds great. Have a great day, guys.
Thank you.
Thank you.
Bye.
Yes, I knew exactly what you were talking about. Thank you. That was pretty good, Ryan.